there are a number of things. We've always thought of MSI-High patients with colon cancer as being different. It started many years ago when we realized, for reasons that are unclear, that the fluoropyrimidines don't seem to be beneficial in the adjuvant setting. And that never made sense, but we observed that in early studies. Dan Sargent sort of figured that out by looking at a couple of data sets without having looked specifically at the MSI-High group in, prospectively. So first we thought, well, for stage 2 patients, MSI-High, we don't use a fluoropyrimidine. We now have some idea of why it might be that chemotherapy is harmful, and that has to do with the immune effect. MSI-High cancer is obviously stimulating the much more robust immune response. So arguably, the fluoropyrimidine may have interfered with the immune response. Don't know if that's the case, but sort of as we put it together, and that's how we looked at it. I don't think we had any sense of MSI-High making a difference otherwise until the checkpoint inhibitors came around, and the study by Dong Li in 2015 ASCO sort of changed everything, where MSI-High patients across any histology, so agnostic to histology, these checkpoint inhibitors worked. And what you realize is that MSI-High is really a code word for having a boatload of mutations. And the simple way to think of it is that the immune system has a better shot at generating an immune response the more mutation, more foreign antigen there is in the body. So I think we've realized it was different since then, and we've done many analyses. And now if you look at the range of observations, Memorial has an observation, which I think is probably true, that patients with rectal cancer who are MSI-High don't do as well, nearly as well, with neoadjuvant chemotherapy. Patients, as we saw today, with checkpoint inhibitors can get very good responses, and yet a third of them don't benefit at all from the checkpoint inhibitors. So this is it's not so easy. And obviously the mystery to me is what makes the third of patients who don't respond to checkpoint inhibitors different. That's going to be one of the most important take-home messages from today. So, but obviously, one of the things that most distresses me is how many patients don't get their MSI status checked right at the get-go. That's got to change. Just as we need RAS status, we need MSI status right away, and then we start working about how to use the new agents appropriately. It's a phenomenal change, considering that we've long ago thought this only had some heritable risk, and that's all it was, and obviously it's much more than that.